Every day, you essentially pay your dues by doing the harder thing when it's the right thing to do.
My name is Alea Penner, and today I will be talking about bracing treatment for spondylolysis and spondylolisthesis in athletes. I will be summarizing the current available research that supports or contradicts current treatment standards and discuss topics of future research that are demanded by a lack of current literature. So why brace? I'll briefly touch on some of the reasons why clinicians choose to brace, which in turn will set up our conversation about what research is available to support or contradicts these claims. While there are many more factors that go into a clinician's decision to brace or not, I've chosen 4 of the most prominent concepts to focus my review. First, bracing is thought to promote bony healing by restricting gross intersegmental and segmental motion. Second, bracing is thought to decrease pain through many avenues, such as acting as a proprioceptive guide, decrease compression loading during ADLs and ambulation, restricting extension and rotation range of motion, and others. Thirdly, bracing is believed to decrease the progression of fracture and/or slippage through improved healing and restricted range of motion. And fourthly, bracing is used as a tactile reminder to adhere to activity limitations throughout ADLs and at times during the return to sport phase. I'll also briefly go over some indications for bracing. However, it should be noted that due to a lack of high-quality clinical trials and inconsistent research findings, Lang et al. Found that clinicians often make the decision to brace based on previous training, personal experience, or individual discretion, rather than through evidence-based medicine. That being said, there are some overlapping indications for bracing found in the current literature. To begin, lack of sign and symptom improvement by 2 to 4 weeks is one of the indications for bracing. However, this was highly variable, and clinician timeframes for bracing varied significantly from clinician to clinician and by geographical location. Others are high pain levels, presence of a true fracture, presence of a spondylolisthesis, lack of patient compliance to activity restrictions, and in conditions when the clinician is concerned for progression of the spondylolisthesis or spondylolysis. After assessing the available literature, I came up with 4 questions I believe to be the most important to address in order to evaluate clinical current treatment guidelines. The first is, does bracing limit gross motion and/or spinal segmental motion during ADLs or sport-specific activity? The second is, does bracing lead to decreased strength and/or changes in posture and gait with prolonged use? The third is, does limited motion prevent the progression of a fracture or slippage? And the fourth is, does bracing improve bony union? And is bony union predictive of better return to sport outcomes and subjective pain? To answer the first question, does bracing limit gross motion and/or spinal segmental motion during ADLs or sport-specific activity? We'll look at a few different studies. The first is a comparative study by Buchalter et al. This study looked at 4 types of lumbar braces, the rainy jacket, a lace-up corset, a TLSO, and a common elastic corset. They used a 3-space analyzer with sensors placed on C7, T12, and the sacrum. The authors found that all 4 braces significantly limited thoracic and lumbar spine range of motion in the sagittal and frontal planes, with the rigid TLSO and rainy jackets being the most restrictive. In another study by Kennelly et al., 10 young and healthy volunteers aged 22 to 44, 5 male, 5 female, performed 4 different tasks: full active flexion and extension, lateral bending, and axial rotation, as well as full active everyday movement, which typically consisted of flexion plus lateral bending plus axial rotation, with and without the orthoses. A 3D motion capturing system and a pressure sensor was used to measure the pressure exerted on the subject's body. The authors found that the range of motion significantly decreased in all loading planes from 42 to 69%, with the largest decrease in axial rotation and the smallest decreases observed in extension and flexion and everyday movements. The differences between the 2 orthoses were small and not statistically significant. Both orthoses had similar stabilizing effects on the thoracolumbar spine, but the authors ultimately found that complete immobilization of the thoracolumbar spine was not possible with either of the 2 orthoses, but the stability increase was statistically significant. A few other studies that are of importance, Miller et al. And Twang et al. Both found that lumbar sacral orthoses and corsets were ineffective at minimizing motion at L5-S1. Each of these studies found that yes, while different types of braces will vary slightly in the amount of range of motion that is restricted in each plane, they do all restrict gross range of motion. However, does this restricted range of motion lead to better clinical outcomes, bony union, or faster return to sport times? Another important consideration is whether or not the amount of range of motion allowed in the brace is greater than or less than that experienced through activities of daily living versus sport-specific activity. We'll explore these questions further in the next slides. So let's take a more zoomed in approach. Another study by Lang et al. Evaluated 12 healthy volunteers aged 22 to 67, with it performed different tasks that required trunk flexion extension and bilateral trunk bending while wearing no brace, a 3-point hyperextension brace, a custom-made semi-rigid orthoses, and a custom-made rigid orthoses. They used 3D optimal motion capture to assess regional, intersegmental, and segmental range of motion. So in summary, the rigid orthoses provided the most regional, intersegmental, and segmental restriction in flexion and extension and lateral side bending movements, with minor differences that were not always significant when compared to the semi-rigid orthoses. The authors found that the hyperextension brace was often insufficient in effectively and significantly reducing range of motion compared to the rigid orthoses and semi-rigid orthoses. It's also important to note that when evaluating the intersegmental motion between L3, L5, and L5S1, and then from L3 to L5 and from L5 to S1, spinal motion was not significantly immobilized in almost all of the orthoses compared to no brace. So considering that most cases of spondylolisthesis and spondylolysis are present between L3 to S1, these results are of note and may suggest that none of the orthoses that were evaluated in the study sufficiently reduced spinal motion at a segmental and intersegmental level compared to no brace. Considering all this information, when we're taking into account the research and we're supporting that the goal of our treatment is to restrict motion at that segment or at the fracture site, we may not even be doing that with the brace. So it's an important consideration, especially when we have most of the types of braces that are commonly used, such as the semi-rigid orthoses, and even with the custom-made rigid orthoses, we still may not be getting the restriction at that level of the fracture that we're looking for in order to promote more healing. Another study by Utter et al. Looked at 10 subjects with an average age of 27 years old. They underwent a video fluoroscopic imaging as they performed a full flexion extension cycle. The figures show changes in intervertebral motion throughout the 8-second flexion extension cycle at L3, L4, L4, L5, and L5S1 levels. The authors found that each of the braces produced a statistically significant reduction in overall lumbar motion during the flexion maneuver, but none of them had a detectable effect during extension. More specifically, at the L3, L4 level, only the TLSO had a statistically significant effect on intervertebral motion during flexion. At L4, L5, all the orthoses were effective and statistically indistinguishable in their ability to reduce intervertebral flexion movements ranging from 48% for the semi-rigid and about 15 to 20% for the other two LSOs. Again, it is of importance to note that no effects were noted for any of the orthoses at L5S1. Considering that a majority of spondy injuries occur at this level, and it might be important to note that this may not be sufficient spinal immobilization. That is one of the reasons it's currently believed to be a good treatment. It is also important to note that none had a detectable effect during extension. So if we're trying to limit either for pain reduction or for decreased compressive loading with the brace, if we're using those thoughts to guide our treatment with the brace, we may not even be getting that kind of response, getting that limited motion and extension that we're looking for with the braces, even with LSO and semi-rigid TLSOs. In a prospective cohort study by Jageti et al., they sought to evaluate how LSOs of varying rigidity restricted full active range of motion and functional range of motion required for ADLs. 10 asymptomatic individuals were evaluated during 15 simulated ADLs while wearing no brace, a corset, semi-rigid LSO, and a rigid custom LSO, using a dynamic motion analysis system with electrogoniometer markers that were fastened onto the skin over T10, T12, and the distal sacrum. The authors found no significant discrepancies between the range of motion recorded in the semi-rigid and custom LSOs for the ADLs. Likewise, functional range of motion associated with the corset and semi-rigid LSOs were only different for 2 ADLs, whereas significant disparities were between values with corset and custom LSOs were observed for 4 simulations. This means that the amount of gross range of motion that was available when participants were asked to go to their active end range of motion is significantly more restricted with the rigid orthoses compared to the semi-rigid LSO and corset brace. However, when examining the functional range of motion required for ADL tasks, there were no significant differences between the custom rigid LSO and the semi-rigid LSO, and only minimal discrepancies when compared to the corset. The authors found that the full active range of motion allowed by LSO braces was greater than the functional range of motion required for ADLs. So according to the study, we might conclude that during a time when athletes are not participating in any sport activity, wearing a corset, semi-rigid, or custom rigid orthoses does not change or limit range of motion any more than wearing no brace at all. However, one important flaw of the study was that all of the participants were asymptomatic. It is possible that the brace may act like a tactile reminder or proprioceptive guide that ultimately limits gross range of motion in symptomatic individuals more so than asymptomatic individuals, potentially due to acknowledgement of injury or fear or presence of pain. Another study by Terry et al. Looked at 10 subjects who were assessed with a custom-made stay, an aluminum stay, plastic stay, an orthoses corset, and no brace. They looked at this to evaluate the effectiveness of lumbar orthoses to restrict lumbar range of motion, with emphasis on restriction of extension, specifically using a spinal mouse system to measure flexion and extension and a pressure sensor to measure load distribution of the back support. The authors found that none of the stays changed the flexion angle and none of the supports prevented flexion bending. All of the supports allowed similar flexion motion. The only one that had the strongest restriction and extension was the custom-made brace, and that resulted in 65% limited extension compared to no brace. So differences with this study, this is where we start to get into a little bit of mixed reviews, because some of the studies, like the previous study that showed there was no restriction and extension, but now we have another study that says that these different types of stays with the custom-made aluminum stay, plastic stay, or the corset are able to limit some extension. One of the theories of bracing treatment is that orthoses can directly reduce spinal loading, therefore decreasing compressive forces on the spine and ultimately creating a better environment for healing and decreasing the progression or slippage of a spondy. It has also been theorized that bracing can indirectly reduce spinal loading by increasing abdominal pressure and core bracing, resulting in decreased spinal compression due to active muscular involvement, therefore potentially relieving pain and improving bony healing conditions. However, according to Lang et al., orthoses are not able to directly reduce spinal load to a relevant dimension, but rather provide mechanical stability and act as a proprioceptive guide to pain. Additionally, most current literature has found that core muscle activation is unchanged or insignificantly different compared with no brace. We'll get into that a little bit more later. At present, the results seem to be very inconclusive. In a systematic review of 35 studies by Enzandia, 8 studies looked at spinal compression and load and lumbar supports. 4 of 8 of the studies showed reduced loading, 3 studies resulted in no change, and 1 study showed reduced compression with elastic belts compared to leather or fabric belts. So again, the results seem to be pretty inconclusive when you look at the research. In a related study by Rubri et al., studying a cadaver model of a burst fracture, spinal motion restriction was assessed with and without an extension brace and custom TLSO orthoses using electromagnetic motion tracking and analysis system to track angular and linear displacement of the fracture site during common patient maneuvers while in the hospital. The authors found that TLSO style braces had little effect on linear translation. In a seated position, the TLSO style braces had restricted gross flexion and extension modestly, but did not influence lateral bending or linear translation. Extension style braces had no effect on fracture motion during any of the activity tested. In summary, the authors concluded that none of the TLSOs evaluated were effective in limiting anterior, posterior, medial lateral, or axial translation at the fracture site. While the study is limited in that the patient population is different than that of a spondy fracture with different causes of injury, as well as the fact that it is a cadaver model that is lacking active spinal stabilization from spinal musculature, it is interesting to investigate how bracing influences the actual vertebral fracture site, which is something that is unfeasible in clinical practice. Leading into our second question, does bracing lead to decreased strength and or changes in posture or gait after prolonged use? In a study by Cons et al., spinal restriction during walking with and without a TLSO was evaluated. They found that peak-to-peak pelvic obliquity and rotation was significantly reduced across all walking speeds, while posterior pelvic tilt was significantly reduced at only the fastest walking speeds. Hip abduction and adduction motion was significantly reduced with spinal restriction across all speeds, while hip flexion and extension significantly increased at only the very slow and slow speeds. A better understanding of the effects of restricted spinal motion on gait may help clinicians predict and avoid development of additional problems from TLSO use or surgical restriction of spinal motion. An awareness of these issues will enable clinicians to monitor patients for problems that may result from decreased spine and pelvic motion. It's also important to consider that because we know that these are changes that occur during walking with and without a TLSO, if we're wearing the TLSO for a very prolonged period of time, we could see changes in posture and gait after use of the brace. This is just all the more reason to determine whether or not a brace is an effective method, if it should be in our current clinical treatment guidelines. And a systematic review by Azendinia et al. Looking at how muscle strength is affected before, during, and after prolonged use of an LSO brace. The authors found that LSOs had no effect on muscle strength in some studies, whereas other studies demonstrated increased muscle strength. Only one study, which included ultrasound assessment of trunk muscle stabilizers, suggested reduced thickness of the abdominal muscles and reduced cross-sectional area of the multifidus muscles. The present review showed that changes in outcome measures associated with muscle work demands were inconsistent in the relation to use of lumbar supports. This review did not find conclusive scientific evidence to suggest that anorthosis results in trunk muscle weakness. Finally, in a meta-analysis of 8 studies by Takasaki and Miki, the authors found no significant difference between maximum strength of trunk flexors and extensors and endurance and fatigability of the trunk extensors following continuous use of an LSO for 1 to 6 months. The most common measures for motor performances were the maximum strength of the trunk flexors and extensors and the endurance and fatigability of the trunk extensors. It was noted that the quality of evidence ranged from low to very low, and that more high-quality studies should be conducted to draw more substantiated conclusions of long-term LSO bracing on trunk motor performance. Moving on to our third question, does limited motion prevent the progression of a fracture or slippage? In a retrospective radiologic and clinical study by Muschik et al., 86 young athletes with spondylolysis or spondylolisthesis were studied to evaluate the progression of Spondy injuries over years of competitive training. These athletes were between the ages of 6 and 20. There were 24 girls and 62 boys. At the beginning of the observation period, 74% of children and adolescents already showed a spondylolisthesis in L5, in addition to the pathological change in the pars interarticularis. 47% of children and adolescents showed no progression during the whole observation period, which was a change in displacement less than 5%. And then in 9% of athletes, there was a partial reversal of the displacement process, which was a spontaneous repositioning at 18 months in isthmic spondies. In 44% of athletes, they found a progressive spondylolisthesis, which was defined as a change in slip greater than 5% over the course of the observation. And for 36 athletes, spondylolisthesis did not progress during the period of athletic training. Overall, spondylolisthesis increased an average of 10%, and at the end of the observation was 16%. The authors concluded that if progression of a spondylolisthesis was defined by an increase in displacement of greater than 10%, only 10 athletes in the study would have displayed a progressive spondylolisthesis. Only one athlete out of the whole study displayed an increase in spondylolisthesis greater than 20%. And it was an 11-year-old gymnast who had 7% displacement at the beginning and 31% displacement at the end of the observation period. It is worthy to note that age at the beginning of the observation had no influence on the extent of vertebral displacement. However, the increase in displacement tended to be higher when the progression phase began at age 6 or 7. While the progression of the spondylolisthesis with continued participation in competitive sports is an important concern for clinicians, this research shows that in spite of intensive daily training, athletes did not experience symptoms during the entire 5-year period. The authors concluded that in light of this research, they found no justification for generally advising children and adolescents with limited spondylolytic and spondylolysis not to participate in competitive sports following appropriate treatment. Moving on to our fourth and final question, does bracing improve bony union, and is bony union predictive of better return to sport outcomes and subjective pain? A stable bony union has been regarded as one way to evaluate treatment effectiveness, set length of bracing timeframes, and as a factor in determining readiness to return to sport. However, this theory has been very controversial due to lack of quality supportive research, as well as available research indicating abundant reports of asymptomatic children with a persistent pars defect. Therefore, it's very important to look at the research to see if bony healing is predictive of better return to sport outcomes, as well as decreased subjective symptoms. Unfortunately, no randomized clinical trials that compare bony union, subjective signs and symptoms, and return to sport outcomes exist as of the day this presentation is being recorded. A meta-analysis of observational studies by Klein et al. Reviewed 15 observational studies comparing the clinical outcome of patients treated with a brace to patients treated without a brace. The study looked at different types of lesions. They looked at acute lesions, which was defined as a hairline defect also referred to as a fissure in the pars or focal bony absorption. Progressive lesions, where the defect is moderately wide and edges are now round, and terminal lesions where the defect is wide and they have sclerotic changes present. After looking at the results of the study, 68% of the acute lesions healed, 24% of the progressive lesions healed, 0% of the terminal lesions healed, and then 74% of the unilateral healed, and 28% of the bilateral healed. So looking at this, if terminal lesions, 0%, none of them healed. So acute lesions are more likely to be healed than progressive or terminal lesions. And then the unilateral lesions were much more likely to heal in comparison to the bilateral lesions. Overall, the study also suggests that 83% of patients treated non-operatively will have a successful clinical outcome at least 1 year after. And the authors concluded that bracing does not seem to influence this outcome. The authors also concluded that in contrast to the high rate of success with clinical parameters, most defects did not heal with non-operative treatment, suggesting that successful clinical outcomes did not depend on the healing of the lesion. It's worth noting that acute and/or unilateral lesions were much more likely to heal after non-operative treatment compared to terminal and bilateral lesions. The study suggested a combination of clinical treatment outcomes, physical readiness assessments, and subjective signs and symptoms rather than bony reunion should be the gold standard for evaluating bracing timeframes and readiness to return to sport. This slide shows the radiographic outcomes, so the percentage of healed defects for each study. They ranged widely from 0 to 62%. So again, we have more research that's a little bit more variable, but again, the summary at the end was 68% of acute healed, 24% progressive healed, 0% terminal healed, 74% of unilateral healed, and then 28% of bilateral healed. I'm looking at the effects of non-operative treatment on clinical outcomes. This is where the 83.9% of subjects had a successful clinical outcome after a minimum of a 1 year follow-up. Success was considered to be excellent or good, with good results with no pain and vigorous activities, no brace requirement, and full unrestricted activities. Clinical outcomes were determined unsuccessful if there was more frequent pain with vigorous activities or pain with ADLs, a brace requirement, and patients considered for a spinal fusion. So 83.9% of subjects having good results, no pain with vigorous activities, no brace requirement, and full unrestricted activities. Those are pretty good results with or without the brace. This slide directly compares effective non-operative treatment with and without bracing on clinical outcomes. In a subgroup analysis, 89% of subjects that were treated with a brace had a successful clinical outcome compared to 85.8% of subjects treated without a brace. There was no significant difference found between the two groups. The subgroup analysis of the clinical effective treatment included bracing compared to treatment without bracing had very low levels of variability that strengthened the generalizability of this particular analysis. So that's a pretty big deal right there. You have, of course, they are observational studies, but it is promising and just shows that we need more research that can directly compare with a randomized controlled trial bracing to not bracing and looking at clinical outcome measures to see what results we would get and whether or not bracing is worth it as a treatment. And just to conclude, clinical outcomes with different types of bracing. So overall, the clinical outcomes achieving excellent or good treatment success ranged from 65 to 100% with varied interventions, including combinations of PT, bracing with different types of braces, TLSOs, semi-rigid, LSOs, corset, or cast, and activity restriction. So it kind of shows us that we're able to get pretty good success with these injuries with a variety of different treatments. And it just shows that we do need more research to kind of come up with better treatment guidelines to really narrow down so we can get closer to that 100% clinical outcome versus the 65%. In a study by Iwamoto et al., 104 athletes with a mean age of 20 years who consulted the author's sports medicine clinic during an 11-year period from 1991 to 2002 with complaints of low back pain and an apparent pars interarticularis defect on plain radiographs were treated conservatively with activity restriction and antilordotic lumbosacral bracing. The authors were looking to assess the efficacy of conservative treatment in athletes with severe low back pain and spondylolysis with a focus on return to sport outcomes. The treatment was aimed at achieving stability of the fracture, partly associated with fibrous union, as well as reducing pain. 35 38.5% of patients discontinued sporting activities due to severe low back pain. With this study, during conservative treatment, after patients' low back pain was markedly reduced, the brace was removed, and then individual training to return to the original sporting activities was started. 87.5% could return to their original sporting activities in an average of 5.4 months after the onset of treatment, and could continue the activity for at least 6 months despite non-bony union. The authors concluded that the outcomes of conservative treatment with activity restriction and bracing resulted in satisfactory return to sport outcomes and were sufficient at reducing or controlling symptoms. It is worthy to note that the study included mostly recreationally competitive athletes, and this may not be generalizable to elite athletes with higher training volumes. Additionally, a majority of the spondies included were at the L5 level and therefore may not be generalizable to all spondy levels. A cohort study by Rossi et al. Included 132 athletes with a mean age of 13 years. They all had a chief complaint of low back pain, radiographic finding of spondylolysis, and participation in regular sporting activity, all of which were seeking treatment in the author's hospital from 1990 to 2002. The authors sought to investigate compliance with non-operative treatment in young athletes and assess clinical outcomes of symptomatic spondylolysis. 65% of the patients stopped all sports activities for at least 3 months, and 46 patients, or 35% of patients, stopped exercising for a variable period of less than 3 months. The grading of clinical outcome after non-operative treatment was excellent in 36% of patients, good in 56% of patients, fair in 4% of patients, and poor in 3% of patients. The authors found that patients who stopped sports for 3 months were 16.39 times more likely to have an excellent result than those who did not stop sports, and found that bony healing on radiographs did not correlate with a clinical outcome. The authors concluded that patients who had a radiologic bony healing did not have better return to sport or subjective clinical outcomes than those without healing. It was suggested that, as shown in medical literature, excellent results could be obtained after fibrous healing, and bony healing might not need to be the ultimate goal of non-operative treatment. So I think this is a very important point. We may not be getting bony healing or bony reunion, and that may not even be an important factor when we're looking at our return to sport or improving clinical outcomes. As this study showed, excellent results might be obtained after having fibrous healing, and that bony healing may not need to be the ultimate goal of non-operative treatment. I had a few lingering other thoughts following my other questions. So we'll talk about some of these before we move on to our summary. But while the effectiveness of orthoses is controversial, as I've kind of laid out, orthoses limiting range of motion or contributing to bony healing is still controversial, and a lot of the research is still somewhat mixed. But patients frequently report decreased pain and improved confidence in ADLs and return to sport while and following the use of an orthose. So this is an important consideration when we're looking at pain science or fear of movement, patients being able to feel comfortable moving. They may be scared to move if they don't have the brace on, but with the brace on, they may feel more comfortable. Looking at some of the research that we went through earlier and seeing that even though the brace may not be limiting range of motion more during ADLs than we think, that it may not make any difference range of motion wise between brace and no brace. It may just make the patient feel a little bit more comfortable and less scared to be moving and normally, walking normally, and decrease that fear of movement, fear of pain, getting back to that, because we know that movement is good regardless. And it is important to consider that almost all of the studies that we looked at were with asymptomatic individuals. So a lot of the range of motion studies didn't really look at patients that were undergoing pain and may have different range of motion with the brace on or without the brace on, just in general, because they are in pain or scared of movement. So that's another important consideration. Another important consideration was that the rigid orthoses braces were associated with the lowest patient compliance among all the orthoses owing to discomfort. The semi-rigid orthoses and rigid orthoses produced high subjective immobilization, whereas the rigid orthoses was more often associated with negative side effects such as skin pressure marks compared to the semi-rigid orthoses. So this is an important consideration when we're looking at the differences between the braces. So we know that most of the research that we went through today shows that the rigid orthoses was the best at limiting motion. But some of the studies showed that the rigid orthoses and the semi-rigid orthoses weren't always that different, weren't always statistically significantly different from each other. So that might be a good consideration when we're thinking about patient compliance, considering the patient's age and making sure that it's a custom orthoses. We want it to be a comfortable brace so that the patients do wear them and are feeling comfortable in them. And another thought and meta-analysis of observational studies, Klein found that brace type and radiographic outcomes varied greatly. So differences between braces and the radiographic outcomes were very widely all over the place, to be frank. That is why part of the reason why we need more research on this topic. We need to get a handle on good treatment outcomes for these patients and come up with treatment guidelines that can help our patients return to sport faster. Some of the literature limitations that I just want to go over were that they're mostly observational studies. Any of the studies that we're looking at, brace versus no brace, are observational. There are no randomized control studies to this date. It would be great if we could push forward for some of those because they're definitely needed. A lot of the studies that we looked at were male dominated, and there was a wide variety of ages. So some of the studies were younger with mean age of 13 years, others were mean age of 20 or 40. So age and small sample sizes were very often what we were dealing with the research. And a lot of the studies were assessing defects at L5. So we have a lot of L5, L5S1, but if there are defects at L3, L4, the research isn't as supportive of those defects. We don't have as much research on different levels. So that's something to consider when you're looking at generalizability of the research. And there are also few studies assessing clinical outcomes as the gold standard. So a lot of the studies look at bony union and don't include the subjective measures to see how bony union and subjective measures compare. We definitely need more research on that. Some takeaways from today are bracing is likely not restricting segmental, intersegmental, or gross range of motion during common ADL activities. So if a patient is not in their sport activity, they are doing their ADLs and they're not participating in any sports, the brace may not be necessary. Bracing may be necessary for decreasing pain, but after pain goes away, it's unlikely with the research that we have currently that the brace is restricting that segment level enough to provide better bony healing. It's likely that there is more fibrous healing, but the brace is likely not stabilizing that spinal segment to provide a better environment for healing. So after pain is reduced and the patient's feeling comfortable doing their common ADL activities without any pain, without the brace, it may be that that's when the time is to take the brace off. So bracing, even for longer time frames, is likely not going to result in core weakness or significant changes in gait pattern following the removal of the brace. So most of the studies that we looked at are not resulting in these big issues that we're thinking of. So prolonged use of the brace, we're not going to end up with a ton of core weakness afterwards, most likely, at least by current literature standards. So that's something else that we can kind of take off of our plate, but we still definitely need to be considering how long we're keeping our patients in the brace, because the longer we're keeping them in the brace, it's possible that with fear of movement and just changes in their movement and changes the way that they have to change their gait for the larger braces like the Boston brace or big TLSO braces, those might result in longer term changes. The custom rigid orthoses that are subjectively comfortable for the patient result in the best adherence and greatest restriction and gross range of motion. So making sure that we're getting the custom orthoses if feasible, especially if you're planning to put the patient in the brace for a long time, pushing for the custom ones will have better adherence and the greatest restriction and gross range of motion if that is the goal. Bracing may grossly restrict extreme ranges of motion experienced during sport activities. So this is another thing to consider. So if the brace, while we are not performing any sporting activities, is not restricting us more than our ADLs, something we may consider is that when we're returning to sport, do we need a brace? Going back in, would a brace be more beneficial to us because it is helping remind us not to go into those extreme range of motion during sport activities. I know that some clinicians will wean you out of the hard brace and move you into a soft brace, but we know that the soft braces aren't necessarily providing the restrictive range of motion that we're looking for during sport activities. So that's just another thing to consider, another point of research that we need to explore. Bony bracing may not be improving bony reunion rates, even in acute cases. So in acute cases, maybe at very prolonged time, like 6 months, maybe return to sport in 6 months. If you keep them in a brace for 6 months, you're attaining bony union, but that may be prolonging the return to sport phase for not a great reason. We may not even get bony reunion in 6 months. So prolonging that process may not be beneficial for the patient, and maybe using more of a subjective outcome measure based on pain and symptoms and special testing would be a better way to determine whether or not a patient is ready to return to sport versus the bony union rates, since most of the research that we had looked at did not tie any of the bony union rates to better subjective clinical outcomes. Bracing may not prevent the progression of spondylolysis or spondylolisthesis. So in the studies that we looked at, the progression to spondylolysis and spondylolisthesis may not be enough for it to be clinically meaningful. I'm not sure that we know exactly what that is yet. We need to, again, compare it to subjective measures, and knowing that there are a lot of individuals out there with asymptomatic spondylolisthesis and don't have any issues, aren't getting treatment, aren't having any pain, kind of blurs the water a little bit. So we need to consider what amount of progression of spondylolysis or spondylolisthesis is too much. And again, like the authors had concluded in that last study, they did not recommend that anyone with a spondylolisthesis or spondylolysis, unless that is asymptomatic, should not be able to return to sport fully, and competitive sports as well. Union rates are not the gold standard for return to sport timelines, clinical outcomes, or evaluating the success of treatment. So most of the research that we looked at shows that union rates are not the gold standard. We need to move to a gold standard where we're looking for clinical outcomes, subjective pain assessments to guide our treatment, versus looking for union rates or a standard time frame for bracing in order to attain this bony healing. However, there could be fibrous bony healing. So the brace, while it does not restrict the motion at the segment, if we keep them out of sport longer, enough time, about like 3 months, to keep them, to allow that environment for fibrous healing with or without the brace, that might be the next thing. But we need to be doing research on all this stuff. We need to come up with clinical guidelines, clinical treatment guidelines with this research in order to really start to get our patients back to, like, return to sport faster, because there's so much variability with clinicians, both MDs and PTs, as far as how to get these patients back to sport quickly and without recurrence of pain following their treatment. These are my references here on the next slides. Thank you for listening, and have a great evening.